Bipolar disorder versus depression. Sometimes it's hard to tell whether someone is struggling with depression alone or whether it's really part of bipolar disorder. This is one of the biggest diagnostic challenges in psychiatry. Bipolar disorder can first appear as depression, mania, or hypomania. If you start out with a depressive episode, you may be diagnosed with major depressive disorder for years, until you eventually experience your first manic or hypomanic episode. At that point, your diagnosis changes to either bipolar I or bipolar II disorder. But here's the problem. Many people go 10 years or more before being correctly diagnosed with bipolar disorder. During that time, they may be treated as if they only had unipolar depression. And that can matter a lot, because the treatments for bipolar depression and unipolar depression are not the same. So, how can you tell the difference? Researchers, including Dr. Gary Sachs, who developed the Bipolarity Index, suggest that there are certain red flags that a depressive illness may actually belong to the bipolar spectrum. Here are 5 key signs to watch for. 1. Your first depressive episode occurs before age 20. The age of onset is one of the most reliable clues. In bipolar disorder, the average age of onset is between 15 and 20 years old. In major depressive disorder, it is often later, typically between 30 and 40 years old. Of course, exceptions exist. Some people have an isolated depressive episode as a teenager and don't have another until decades later. But in general, when mood symptoms show up in the late teen years, clinicians are more suspicious of bipolar disorder. 2. You don't get better with antidepressants. Another red flag is how you respond to treatment. If you've tried antidepressants, but your depression doesn't improve, or you actually get worse, more anxious, restless, or wired but tired, it may be a sign of underlying bipolar disorder. In fact, studies have shown that in some people with bipolar disorder, antidepressants can trigger manic or mixed states. Mixed states are especially tricky because you feel both depressed and agitated at the same time. It's also possible to respond well to antidepressants early on, but then later find they stop working as bipolar illness becomes more evident. 3. Family history of bipolar disorder. Genetics play a major role in bipolar illness. If you have a first-degree relative, such as a parent or sibling, with bipolar disorder, your risk is much higher. In fact, twin studies show that bipolar disorder is one of the most heritable psychiatric conditions, with heritability estimates around 70-85%. So if depression runs in your family, but especially if someone close to you has bipolar disorder, your own depression may actually be part of that same spectrum. 4. Multiple depressive episodes in a short time. Unipolar depression often involves 1 or 2 episodes that may or may not return over the course of a lifetime. But in bipolar disorder, depression tends to be cyclical and recurrent. If you've had 3 or more depressive episodes within 5 years, that's a red flag for bipolarity. Why? Because bipolar illness typically follows a pattern of episodes: depression, mania, or hypomania, another depression, and so on. Even if manic or hypomanic episodes are subtle or go unnoticed, the frequent cycling between episodes is a clue. Sometimes hypomania is overlooked because it doesn't cause major impairment. You might just feel more energetic, more social, and more productive. People often don't view that as an illness. It just feels like a good week. But in retrospect, these subtle hypomanic periods can reveal that the depression you've been experiencing is actually part of bipolar II disorder. 5. Rapid recovery with mood stabilizers. Finally, response to medication can be a diagnostic clue. If you take a mood stabilizer, such as lithium, lamotrigine, quetiapine, or valproate, and your depression lifts within about a month, that could indicate an underlying bipolar process. Now, it's not absolute. Psychiatrists sometimes add mood stabilizers to cases of treatment-resistant depression, even when it isn't bipolar. But when patients respond quickly and fully to mood stabilizers, it makes us think harder about whether bipolar disorder is the underlying illness. Why does this matter? Because the treatment approach is different. For unipolar depression, antidepressants are the mainstay. For bipolar depression, antidepressant monotherapy can actually be harmful. Instead, psychiatrists often use mood stabilizers alone or in combination with antidepressants. The wrong diagnosis can delay recovery and even worsen symptoms. The right diagnosis can mean the difference between years of struggle and real stability. So, if you or someone you know has depression that fits some of these red flags, it may be worth talking to a psychiatrist about the possibility of bipolar spectrum disorder. That's it. Thanks for watching. See you next time.